So you're faced with a patient who has a regular narrow complex tachycardia. You know the differential diagnosis is pretty broad, but the correct diagnosis demands a very specific treatment. Well, the key to solving this entire clinical puzzle really lies in a deep, mechanistic understanding of one critical structure, the atrioventricular node. And in this explainer, we're going to dissect that mechanism completely. Here's our game plan. First, we're going to establish the two completely distinct roles the AV node can play in supraventricular arrhythmias. Then, we'll actually visualize the electrical circuits involved before we introduce adenosine as an incredibly powerful diagnostic tool. After that, we'll apply all this knowledge to a couple of distinct clinical cases and then finish up by looking at some advanced, subtle clues you can find on the ECG. All right, the very first principle we have to establish is a foundational dichotomy. In any given supraventricular arrhythmia, the AV node is playing one of only two roles. It's either just a passive conduit for an impulse that's generated somewhere else, or it is an essential, active component of the arrhythmia's circuit. This distinction is absolutely paramount. Now, this table presents that fundamental classification perfectly. In what we'll call type A rhythms, think atrial fibrillation or flutter, the arrhythmia starts up in the atria. The AV node in this case is just acting as a passive, rate-limiting conduit, just passing those impulses down to the ventricles. In stark contrast, for type B rhythms, we're talking AV nodal reentrant tachycardia or AV reentrant tachycardia, the AV node is an indispensable piece of the re-entry circuit itself. Without the AV node, that circuit literally cannot exist. Okay, so let's visualize these concepts. Moving from a table to some schematic diagrams is really going to help solidify these distinct electrophysiological pathways in your mind. This slide illustrates the concept perfectly. Over on the left, you see a type A mechanism. Some ectopic atrial focus is firing off, and the impulse is just passively conducted through the AV node. Now, in the center, you have the classic type B rhythm, a reentry circuit that's confined entirely within the AV node. And on the right, you see another type B variant where the reentry circuit uses the AV node for the antegrade conduction and an accessory pathway, the AP, for retrograde conduction. And this classification has profound therapeutic implications. For type A rhythms, giving AV blocking agents like beta blockers or adenosine won't actually terminate the underlying atrial arrhythmia. They're just going to slow the ventricular response by increasing the block at the AV node. But, and this is key, in type B rhythms, those same agents can terminate the tachycardia by interrupting the re-entry circuit at its critical link, the AV node. Now, to convert the actual atrial rhythm in a type A case, you have to turn to completely different drugs, like the antiarrhythmics procainamide or imiodarone. So, understanding the mechanism is absolutely crucial. And this brings us to our most powerful tool for making this distinction right at the bedside, adenosine. And I want you to think of it as not just a therapy, it is a precision diagnostic agent. The genius of adenosine really lies in its pharmacokinetics. It's an ultra-short-acting drug, and what it does is induce a transient but profound high-grade blockade of the AV node. This brief pause in AV conduction is our diagnostic window. It lets us pharmacologically interrogate the AV node's role in the tachycardia, either by terminating the rhythm or by unmasking the underlying atrial activity. So let's apply this principle to a clinical case. This is going to demonstrate adenosine's dual role as both a diagnostic and a therapeutic agent. Okay, here is the initial rhythm strip. What we see is a regular, narrow complex tachycardia at a rate of about 160 beats per minute. The P waves are not clearly discernible at all. This is that classic diagnostic dilemma. And the definitive clinical intervention is performed. A rapid intravenous bolus of adenosine is administered. Now observe the result. The tachycardia terminates abruptly, converting to sinus rhythm. This response is pathognomonic. By terminating the arrhythmia, adenosine has proven without a doubt that the AV node was an essential component of a reentrant circuit. The diagnosis is therefore confirmed. It's a type B, AV node-dependent tachycardia. All right, now let's consider a contrasting case where adenosine doesn't terminate the arrhythmia but instead reveals its underlying mechanism. On the left, we have an example of what could be misinterpreted as a primary SVT at 240 beats per minute. And on the right, another regular tachycardia is shown at 130 beats per minute. Now, following adenosine administration in both of these scenarios, the ventricular rate slows dramatically. This transient AV block unmasks that underlying classic sawtooth pattern of atrial flutter.
Adenosine did not convert the atrial rhythm, it just revealed that the underlying mechanism was a type A rhythm with the AV node conducting at a 1-to-1 or 2-to-1 ratio.
Beyond the response to adenosine, the baseline ECG during the tachycardia itself often contains subtle but critical clues to the underlying mechanism. So let's examine a few of those. This 12-lead ECG is from a patient with Wolff-Parkinson-White syndrome during what we call orthodromic atrioventricular reentrant tachycardia. Notice that the QRS complex is narrow. This happens because the antegrade conduction, so from atria to ventricles, is proceeding down the normal AV node His-Purkinje pathway. The impulse then returns to the atria retrogradely through the accessory pathway, completing the circuit. In this situation, the retrograde P waves are often just buried inside the QRS complex, making them totally invisible. Now, I want you to really examine the inferior leads, that's I, 3, and AVF, on this tracing. You see that small negative deflection, that little blip, immediately following each QRS complex? That represents a retrograde P wave, which tells us that the atria are being depolarized from an inferior to superior direction. This finding significantly narrows the differential diagnosis down to a reentrant tachycardia like AVNRT or AVRT, or possibly a junctional tachycardia with 1-to-1 retrograde conduction. Here we see another really common finding during SVT, marked horizontal ST depression, especially in the precordial leads. This can be alarming and is often mistaken for acute myocardial ischemia. But notice the bottom strip. Upon conversion to sinus rhythm, the ST depression resolves instantly. The crucial diagnostic point here is the timing of that resolution. Rate-related ST depression is a physiological electrical phenomenon that resolves the very next beat after conversion to a slower rhythm. In contrast, ST depression due to true myocardial ischemia, which is a sign of cellular injury, resolves gradually as myocardial perfusion is restored. As the source material says so well, myocardial ischemia cannot come and go from one beat to the next. So let's conclude with a thought experiment that really synthesizes this entire discussion. If you administer adenosine to a patient with irregular, narrow complex tachycardia, and it neither terminates the rhythm nor unmasks atrial flutter waves, what alternative and perhaps less common electrophysiological mechanisms must you now consider? This question forces a clinician to think beyond the most common paradigms and really exemplifies the continuous diagnostic process that is so central to clinical electrophysiology.